Hi, everyone. This is Dr. Mancini, and I want to thank you for taking the time out to see this awesome opportunity that you're going to have, which is an interview that I'm doing with a good friend and a colleague, Dr. Paul D. Kim. He is a surgeon at the Alvarado Spine Institute, and he's going to give you more details about the quality of care that they provide. But I just want to say a few things about Dr. Kim. Dr. Kim, he graduated with honors from Cornell University, an Ivy League school, and he went on to Columbia University for medical school. And a lot of times, I just want to stop right there because a lot of times people want to know, hey, if I'm going to go see a surgeon, is this surgeon qualified? Okay. Does he come from a school that's considered high caliber? And that's generally the baseline that we're looking at when it comes down to a highly proficient surgeon like Dr. Kim with the schooling that he's had. But what's really interesting is, and I was just mentioning this to Dr. Kim, is I was asking my patients just today about what they look for in a surgeon. And not one of them mentioned Ivy League schools. But by the way, that's a really good school to be graduating from. But what they did really say, and it was pretty consistent, is I want a surgeon that listens. I want a surgeon that hears what my concerns are. I want to trust this person that if I'm going to go under anesthesia, I got to feel a deep sense of trust that I'm going to be taken care of. So other views were they said, I want to make sure that the surgeon gives me a balanced view, like truly what to expect. Maybe not the worst case scenario, but what are the possibilities of what could go wrong? And also, I want a feeling of optimism that my surgeon's really going to look out for my best interest. So a lot of these responses that I received from my patients was just human nature. We just want to trust. And to have a surgeon that we can trust, that's a patient-centered doctor. When I went on to look at some of this background with Dr. Kim, there's one quote that came out that stood out for me, and there were some things in the quote that I like to extract and maybe chat with Dr. Kim about this. And the quote was the following. He said, quote, "It is an honor to be entrusted with my patient's health. I promise to use my knowledge and skills to provide honest, well-informed, non-operative and operative spine care to my patients." So Dr. Kim, the first word I'm pulling out is entrust. And that goes along with every single patient, that they need to feel a sense of trust. And the fact that you can feel that your patients can trust you enough to receive surgery is a big, big deal for them. What's your thoughts on that process when it comes to trust for a patient?
Thanks, Mario. Thanks again for the very kind words and the introduction. But yeah, so most of the stuff that we do is key, and no one wants surgery, right? So you're in a vulnerable state, you're in a lot of pain or have a lot of dysfunction. So, and it's I hate to kind of put a corollary to it, but let's say you have a broken car, you don't know what's going on with it. It's going to cost you a lot of money, cost you a lot of pain. So you just want to trust the mechanic to figure out what's going on and fix it. So I think not that it's an exact correlation because it's your health, but you have to trust what the person's saying and make sure that that's exactly how you said that their best interests are in mind.
Yeah, perfect. So you're really listening to the patient. You're really listening to what their needs are.
Exactly. And then also, as you mentioned too, it has to be a balanced view, so I have plenty of patients who, everyone wants to be pain-free and have full function, but let's say if it's too risky, or let's say the surgery won't help that much. So I always try to give a percentage ballpark to see what percentage the surgery will help you.
Mm-hmm.
So in certain cases, hey, someone has a lot of medical problems and needs extensive surgery, I would say, hey, I think the benefits don't outweigh the risk, so I wouldn't recommend any elective surgery in this case. So I think trust, you have to build trust, you have to be honest with the patient, give them a realistic picture of what to expect, before and afterwards, and what to expect,
Mm-hmm.
a year down the line.
Yeah, so you give them a balanced view of that. You look at the, down the road, what do we expect, so that they're not going to come up against any surprises as well.
Try not to, sometimes you want to listen to what you want to hear, so to speak. So we try to create it's complicated, it's medical. That's why I went to school for so long, but you try to create a realistic view of what to expect, right afterwards and a year down the line. And if we can make you better, then we recommend it. If we can't, with a decent high percentage, then we let you know too.
Perfect. Thank you for that. And the second part of that quote was, well-informed, non-operative and operative spine care to my patients. And I can tell you just from my personal experience, where you are really giving these patients many options, and surgery not being the only one, it's really great to hear, because as a surgeon, I'm sure you have plenty of surgeries you need to do. So you're kind of almost telling people they don't need surgery more than they need surgery. Do you have a tendency or average of patients that are needing surgery versus not needing them?
Yeah, absolutely. At the Spine Institute, we tend to be pretty conservative. I think we ran the numbers at some point a couple of years ago. I think less than 5% of people who walk into our clinic end up needing surgery.
Wow, 5%.
So it's a very low number. So, we don't think of ourselves just as, spinal surgeons, but as spinal specialists. So, someone walks into the door and has, pain. No one's going to have a perfect spine. We maximize conservative care as much as possible. Let's say if someone someone has intractable pain or foot drop or can't walk, that's a different story. Then you think, more surgery if we can't help you. But, majority of people, vast majority, they don't need surgery. And, less than 5% of people who walk into our clinic end up getting surgery.
Less than 5%. That's much lower than I expected. And that brings up another thing that I hear from my patients when I recommend that they need to go see a spine surgeon or they need to go see you. Immediately, the first statement is, "I don't need surgery." And I always and I say clearly, you don't need surgery, but what you do want on your team is a doctor that has seen the worst of it. And how far are you from the worst of it, so that he can give or she can give you perspective on where you are? Because right now, Mr. Patient, Miss Patient, you're in a lot of pain right now. So you need to get a clear, objective viewpoint from a person that's seen the worst of it. What's your experience with that, with patients coming in from that mindset?
Yeah, so people a little wary when they first walk into the office when they see this, Spine Institute of San Diego. But as I mentioned before, less than 5% need surgery. So as long as you can go over the images and reassure patients that, let's say a patient has a very small disc herniation or angular tear or whatnot, they're in a lot of pain because all the pain fibers on the outside of the disc, and it may seem like, oh, I'm in so much pain, I don't, I may need surgery, I'm scared. But as long as you go with the MRI and natural history of it, I think at the end patients are pretty reassured. Once you go through the imaging, their symptoms and a natural history of how things play out.
Have you seen, that brings up a question, have you seen that when you give people context for their pain and you clearly communicate to them that they don't need surgery, does that shift anything in the patient? Have you noticed that? Does the patient leave?
Well, they're happy, first of all. So ecstatic, oh, thank you so much. Thanks for clarifying that. So, I mean, as with anything, devil's in the details. So it really depends on your pathology and where you're at. But I think I would say for the most part, once you explain what's going on and their imaging studies, most patients are pretty happy they came and got context.
Got it. Okay. Because context really does give people sense of control or ability to move in a direction with a little more certainty, just because they have a sense of knowing what it is and what it is not. So it gives them a little more direction. And when you feel a little more certainty, it does shift the nervous system more in a calm state. So they have a little more clarity. One thing I teach my patients a lot is once you have context or a level of understanding, your nervous system starts to shift more into what we call health, growth, and restoration, or a parasympathetic state. Because often when you're in pain, you go into the sympathetic dominant state, the survival mode. And then one of the first things that happen is your frontal lobe shuts off. That means you don't make the right decisions. And sometimes you could be impulsive in the decisions you make. So getting context is so powerful, having the patient walk out knowing I don't need surgery, or yes, I do need surgery. Have you found that where people have a sense of relief knowing that they do need surgery? I'm curious, have you had that experience?
Yeah, I mean that means they're in a lot of pain or a lot of dysfunction,
Yeah.
so that it's you'll see things on both sides of the spectrum.
Okay.
So for instance, today I saw someone with you know, patient saw a couple of specialists, and patient had a foot drop with foot was flopping around. The MRI showed some pretty severe nerve compression, and then I recommended surgery because the patient can't walk very well, had several falls, and was ecstatic that we recommended surgery. So it really depends on the situation. So the patient's happy that there's a explanation for his symptoms and there's
Hmm.
a solution.
Yes, yes. With that said, are there certain things that you would say clearly this is a surgical case versus not? Is there a way to differentiate that between the two?
There is, I mean, to give you context, people come in with a degenerative disc, let's say at 4.5 or 5.1, the first time they're in pain, they're used to being healthy and active, and they come in, oh my gosh, I'm in, I have a degenerative disc at 5.1 and never had
Hmm.
this before. I'm used to being super active.
Hmm.
And the context is that most people have degenerative disc as we age. It's a fact of life. The blood
Okay.
supply gets less and less as we age, and almost everyone has degenerative disc as we age. So once they found out, excuse me, sorry,
No worries.
that it is a fact of life and doesn't necessarily mean that you need surgery, they're relieved. And it's just unfortunately a fact of life, just arthritis. I'm sure you see all that too. Patients
Sure.
have
Sure.
arthritis and worried about it, but unfortunately it just happens.
Got it. Got it. Okay. Um, what I would like to know is, does imaging, when you get an MRI, does it always going to correlate with their pain levels? In other words, can the MRI look extremely bad and their pain levels not be as bad, or can their MRI look really bad and their pain levels equal that? In other words, do you use the MRI as a conclusive evidence for their pain, or have you seen it not equal what they were feeling? Have you ever had that experience?
Yeah, more often than not, you'll have, let's take both views. You'll have someone with a big whopping disc herniation. It looks terrible on the MRI. The
Hmm.
report's terrible, and then the patient's walking as some back pain, but walking around. So,
Yeah.
okay, so doesn't need surgery. We'll just watch this. The other side of that is that someone has what's called an annular tear. So it's a tear on the outside of the disc. It doesn't look that bad on MRI. It's a little white spot, but
Okay.
that's where all the pain fibers are. And something like that doesn't need surgery, but there'll be a lot of pain in the acute phase because that's where all the pain fibers are. So that's the opposite end of it. We're always taught and are trained to, you got to correlate the patient's symptom with the imaging. So but the most important part are the patient's symptoms, not the MRI.
So, and that would be a perfect example of what I call patient-centered doctor, who's really focusing on the patient and not the MRI.
Yes.
That's why we do a lot of work with you. What's interesting is that a lot of times when we're seeing your patients, we're using acupuncture in these possible surgical cases. A lot of times the pain and inflammation goes down, and they realize that the pain generator wasn't the disc, or it wasn't the spondy, or wasn't anything other than just a lot of inflammation around it. How do you,
Sure.
is so is there a way to know the pain generator, or until you treat, you're going to know what's left? Because we as acupuncturists can't push a disc back in, but we can get
Sure.
the inflammation down around it. So is there ways to know if what is the pain generator on your side?
That comes mostly from the examination correlating with the imaging.
Okay.
So let's say someone has back pain, they have more pain with extension, and
Hmm.
the X-ray showed they have a lot of facet arthropathy.
Okay.
Then you would say, hey, the facet joints or arthritic facet joints are the cause of pain.
Okay.
So you have to, the patient has more pain with flexion and has a degenerated disc, and you assume that the disc is the pain generator. So we correlate the imaging with the physical exam findings.
Okay, perfect, perfect. So you have more accurate, more sense of certainty based on your exam findings to determine the pain generator from that point. Got it.
Correlate with
Okay,
the images.
got it. Okay. And one other important question, this might be one of our last questions, is how do you differentiate what you do compared to what they used to do prior to minimally invasive surgery? In other words, the old way of doing back surgery versus what you're doing now. How do you differentiate that?
So the key point is that we're doing the same surgery. So if a nerve is compressed, you have to decompress the nerve. If a spine is unstable, you're still stabilizing the spine. So we're trying to minimize collateral damage. So instead of making a big, huge incision along the back where we look at everything, take down all the ligaments, we use smaller incisions so there's less, it's called collateral damage. So we're damaging less tissue to achieve the same goals of surgery, to either stabilize or unpinch the nerve.
So it's really just minimizing the damage of what occurs when you're getting into the surgical site.
Exactly.
Okay, so the surgery itself is the same, is that you're minimizing. So basically they're going to have faster recovery, or what's the outcome difference?
So it's faster recovery, so less time in the hospital, less chance of infections, less pain medication, and quicker return to function. Those are the big advantages.
Okay. Okay. So getting back into their life right away. And would you say the difference between the older strategy and what you currently do, what's the difference in turnaround time as on average?
So let's take, for instance, objective data. So hospitals. So someone has a 1-level fusion. Majority of my patients are gone in 1 to 1.5 days.
Oh, wow.
If you had a traditional approach, maybe they stay there in 3 or 4 days.
Okay. And then the recovery time also is much faster outside of that for rehabilitation.
Exactly.
Okay. So across the board, minimally invasive spine surgery is just an evolution of the older way.
Yeah, still an evolution too. So it's going to get more and more common as time goes along.
Got it. Got it. Okay. Perfect. Perfect. So, Dr. Kim, if the audience wants to know a little more about you or where they can find you, where can we find you?
Sure. So we have a website, www.siosd.com. There's 2 of us, myself and Dr. Ramin Rezadeh. So, we have offices all throughout the county, San Diego State, Encinitas, El Centro, and Escondido.
Okay.
And, happy to evaluate you.
Perfect. And what I'll do is I will also put the information on the link for the folks if they need to get access to you, your phone number, as well as your office information. So I do highly encourage anyone that may not need surgery, but really needs to know the bigger picture. Basically what I always say, stand on top of the shoulders of a surgeon and see it from a different perspective. I highly encourage you to consider Dr. Kim. We've been working with him for quite a few years, and our patients can't say enough good things about him. So Dr. Kim, I want to thank you so much for taking out the time today. And I appreciate all the work you do, all the good work you do.
All right. Thanks for the kind words and thanks for inviting me.
Absolutely. You have a great night. Take care.
Okay. Take care.
Bye-bye.
All right. Bye-bye.